One question for you, Nancy, is of all the things you mentioned, if someone was to take away one thing, what do you think is the most important element to reduce unnecessary readmissions?
Something that's clinical, but it's something that can be summed up in one word but has a lot of complexity to it, and that word is communication. And so that's a very important, it's important to look at the communication whether or not it is paper or electronic. It's important to look at the communication to whether or not it's appropriate in its complexity, as to whether or not it is two-way communication, whether or not it is one-time or ongoing communication. But I would say that most often coordination difficulties are the result of poor communication.
Yeah, and sort of a follow-on to that is something that was really great is you kind of talked about a lot of different settings, but knowing that a lot of the people who joined today are from primary care, what advice would you have for people in primary care about how they can better partner with all these different players and sort of lead when it comes to reducing readmission?
So I believe that discharge planning, as I mentioned before with the Olympics analogy, is a team sport. And I think that very often when we take a look at what's going on with a provider, we fail to widen out the lens and talk about what's going on overall in the practice. And there are so many members of a practice that have touch points with patients and families that can be wonderful ambassadors for good coordination of care. Whether that's a receptionist who gets a call and is able to understand they were asking about X, but I really think there's an underlying concern here of why. And so that the person, everyone from the receptionist to the medical assistant who is rooming the patient, who recognizes that they're particularly upset today because they had to rush to get here and they've had 3 therapy appointments today. And that's maybe a warning sign that maybe we have patients here and families who are overly stressed with the care plan that we have given. So when you have no-shows in a practice, that's a sign to you from a patient and their family. If we only look at it as a statistic, we're only going to say we have 20% no-shows. That's 20% of families that require an outreach to figure out what's going on and why that person didn't come in.
That's great. And you know, one thing that I really that really stuck out to me about what you said was about folks referring to places or working with places that they hadn't been to. And to your point about communication, it seems like that's something that, you know, people could do to start to generate that, you know, better relay race handoffs, to continue your analogy. So the last thing is, what are some concrete steps you would recommend that people take, especially if people on the webinar today are working with a bunch of different practices who are maybe at different levels with this? What's one thing, one next step that you would recommend they take as they're thinking about this?
Well, I think it's important for a practice to use the tools that they have, and I was so pleased to see that so many had electronic health records, but to try to help them to understand, using their electronic health record system, what is their patient population, what is their no-show rate, what percentage of their population has been hospitalized in the last year, in the last 3 months or 6 months, when was the last time some of their patients with complex needs made it into their office, or have they lost track of them? Is there a way to figure out whether or not their medications have been renewed? So really teaching them to mine their own data. We're always looking for reports that come down from on high, but very often if we're working with practices, we find that they're getting to know their own practice and their own patients raises for them those issues that become most important for them to solve. But the absence of that data often is they're missing clues that are right there in front of them.
Great, so I think we have time for this one more question. A lot of thanks. And I agree with the person who posed this question for addressing the patient and family. It's supposed to be at the center of all this work. So thanks for that. Could you talk more about the reality of home care and expecting families to cope with that, especially with limited time for teaching in hospitals, and that primary care offices may not have the information or be paid to do this kind of education? Can you talk a little bit about that?
Sure, and I think that this is firstly understanding which of your patients and families, almost in a triage sense, need more help or don't need help. If you're sending somebody home with something that isn't too complicated and you're sure that they understand how to do it, you can set that plan in motion and walk away and only have an early warning sign for when something goes wrong. But if you have a complicated case, if it is a person who lives alone or a person with a just as frail a partner as they are, and you have the two of them, sometimes literally the blind leading the blind, having to take care of each other, that's when you know that you really need some additional help. That's often an opportunity to probe a little bit further and find out if there's an additional family member. Where are the adult children? Is there a neighbor? Is there a partnership that you can have with your practice, with a nursing school or a pharmacy school that may be able to go into that home and be more helpful, go in and do some of that teaching and training? Are there technology resources that you can bring? Is there a TV station in your community, a cable TV station that will run community and patient education? Is there a video, and I use the word video and I use air quotes, is there some form of a film or a YouTube that you can use to show this person how they can be doing what they need to be doing better? And is there a support group? Many of our patients go home with conditions that are shared by others as well. Is there a resource or a support group in the community? Is it the Alzheimer's Association? Is it the Cancer Organization? Is it an organization for persons who have had surgery? What are those resources in the community? So very often we don't ask our social workers or even persons at our United Way or other help-finding organizations for resources in the community. It's going to take this entire community to help make these people better and keep them in the community. And we all have a vested interest in that. People really overwhelmingly desire to be home and well cared for and safe in their communities. We can achieve that if we think outside the box and outside of the four walls of a hospital or a practice, and think of the four walls of their home as the place to receive care or to live a healthy life.